Good morning, everybody. Kindly mute your mic, please. अपने mic को बंद ही रखें. Yes. This is Dharminder Kumar, Assistant Training Coordinator of H&FW and host of today's meeting. Today we have with us Dr. Sunite A. Ganju, ma'am. She is Associate Professor, GMCH from Mandi, Government Medical College and Hospital, near Chowk, Mandi. And she is going to take session on infection control and safe injection practices. Before I call her for presentation, I would like to call Dr. Harsharan Kaur, Principal of SLBS, to address the meeting and discuss some key points of this meeting. So welcome, ma'am. Please address the meeting. Thank you.
Thank you, Mr. Dharminder, for organizing these meetings. And for, I think, last 10 days, we are having these webinars every day. We are talking about the COVID-19 series. So yesterday we had talked about vaccination, COVID vaccination. And in that aspect, Dr. Sonika, she taught everybody so well. And I think one thing was left, that the adverse event following immunization. I will just like to say upon that everybody should have the anaphylaxis kit for the management of any adverse event and will be linked to the nearest health facility management center in case of referral for medical management. So this is very important point which was left yesterday. So please add upon this point also to your knowledge. And today's topic is the infection control and safe injection practices. So because of this COVID vaccination, we are going to start for the age group of 18 to 44 years. Everybody is doing all these immunization programs for last so many years since they have joined this job. But still, I feel there is a need to have a repetition of the work we are doing, and we have to learn the things which mistakes we were making. We have to improve upon that, and we have to learn new things from Dr. Sunite Ganju. She is Associate Professor in Chowk, and she is looking after the biomedical waste program also. And she is an expert teacher, and she will share her knowledge with all of us. And I thank you, all of you, to join this webinar. And I welcome everybody for this webinar. The God has given us the opportunity to be together and share our knowledge. And I have found for last days that nobody is asking any question. So please come forward in the end of the session. If you have any queries, any questions, you please ask. So, and you can share this knowledge with your near and dear friends also who are in medical profession. So I want maximum people should get benefit from these webinars. And I will ask you people to please circulate the same webinar, the topic with your friends also, with the medical professionals, with the supervisors, with the healthcare workers, with the Ayush doctors, or the Ayurveda doctors, or the pharmacists, our lab technicians, whosoever can get any benefit from these webinars. So it will be our privilege. So I welcome you, ma'am. You please now start your lecture. I hand over the mic to you. Thank you.
Thank you so much for your kind words, ma'am. Thank you.
Thank you.
So good morning, everybody, and welcome to this topic. We'll soon be starting our presentation, and thank you all for joining also. So today's topic, I think I'm audible. So today's topic is COVID-19 infection prevention and safe injection practices. So this is an important topic, as you can understand. that the main stay in prevention of COVID-19 is infection prevention and also safe injection practices. So we'll be talking briefly about COVID-19 and then the major things which we have to deal with. That is hand hygiene, respiratory hygiene, physical distancing, universal masking, disinfection practices, and safe injection practices. Now, as we all know that SARS-CoV-2 is an evolving virus. We have been dealing with it for the past year, and it represents the third coronavirus associated pandemic, which has emerged from a species leap from wild animals to humans. The first one was in 2003, which was severe acute respiratory syndrome. And the second one was in 2012, which is the MERS, the Middle East Respiratory Syndrome. Intensive infection preventive and control strategies will help to prevent the spread of COVID-19 as we have been seeing for the past 1 year. Now, COVID-19 is an RNA virus. The size is about 60 to 140 nanometers, and the appearance is like a solar corona, and it has a lipid envelope. Why I wanted to tell you is that it is an enveloped virus, which is very much important, being, because we use hand washing for disinfection and cleaning our hands. The incubation time is about 2 to 14 days, taking an average of 5 days. And the virus mainly spreads from person to person, that is droplets, contaminated hands, and between people who are in close contact, that is within 6 feet, and then also contaminated surfaces. So as you can see in this picture, the transmission is mainly from small droplets, that is about less than 50 microns, the large droplets, which is about 100 microns, then direct contact and direct contact with contaminated surfaces. Now let's see the route of transmission. The virus mainly spreads from person to person, that is direct, indirect, and close contact with infected people. The airborne transmission is basically respiratory droplets, and it is produced when an infected person coughs or sneezes or talks. The total volume of droplet count increases with loudness during a choir practice or in a fitness class. The droplet nuclei are basically aerosols, and they remain suspended in air over long distances and over a period of time. But it has been seen that the quantity of RNA detected is extremely low in a large volume of air. The second important is fomite transmission, that is contaminated surfaces, that is respiratory secretions or droplets expelled by infected individuals that can contaminate the surfaces and objects, creating fomites. Viable SARS-CoV-2 virus and the RNA detected by RT-PCR can be found in these surfaces, on those surfaces for periods ranging from hours to days. And transmission may occur indirectly through touching these surfaces which are in your immediate environment. COVID-19 is also a stable virus. It has been seen that it can remain in the aerosol for 3 hours, copper 4 hours, cardboard 24 hours, plastic and stainless steel, it is up to 2 to 3 days, and even claims up to 9 days. It is stable in urine and stool to a temperature, to a time period of about 1 to 2 days. And it's more stable in diarrheic stools, that is up to 4 days, because it has a higher pH than the normal. Now let's have a look at the R0 number. It is very important as per the infection control. It's called as the magic number. The reproductive number is the R0 number. It is the average number of secondary infections which are produced by an infectious case in a population where everyone is susceptible. and it measures the transmission potential of a communicable disease. Now, when the R0 is more than 1, that means that an infected individual is expected to infect a number of subjects that increase exponentially with increase in the R0 value, and the disease is expected to spread through the susceptible population. When R0 is less than 1, each case transmits the disease to less than one individual, and the disease is expected to die in the population. The other number is the RC number, that is the control reproductive number. That is, it can modify our R0 number with the control measures adopted. These measures could be related to the duration of contagiousness, likelihood of infection per contact, and the contact rate. So control reproductive number is modifiable, and if the values are below 1, then the disease will be eventually eradicated. At present, the R0 value for India is 1.32. That means on an average, a person can infect more than one person. So to summarize, I would say that coronavirus is an enveloped virus. It spreads primarily from person to person through droplets. It can be transmitted also from a pre-symptomatic, asymptomatic person. It can emit from aerosols when we talk or breathe. And in the aerosol, it can float or drift around the air up to 3 hours. And it can spread from contact with infected surfaces or objects. And the herd immunity is yet to be achieved. So our basic focus should be on the infection control measures. Now let's go one by one over the infection control measures. So the first one is hand hygiene. So let's see what our hands are carrying. They carry resident microorganisms and they carry transient microorganisms. Resident microorganisms are the normal flora, and these are usually deep-seated in the epidermis and do not cause any infections, and they are not easily removed. Transient microorganisms are not a part of the normal flora. They represent recent contamination and can cause infection, and they can only be removed by a good hand washing technique. Then number 2 is that we touch the face all the time. That is because it is, it is a habit with us that we touch our face. And the easiest path for SARS-CoV-2 transmission are the eyes, nose, and the mouth. And there are several studies which have been seen that average face touch is about 16 to 23 times per hour. And in medical professionals, it is 19 times per 2 hours. So almost half of the face touch is involved with the mouth, nose, and the eyes. So the bottom line, why I wanted to impress upon this slide is that we need to avoid touching our face and increase the awareness of where our hands are. So that would help us to maintain the hand hygiene. So hand hygiene should be maintained, and clean hand count every day should be increased as the day passes. Now, again, infection can be caused, apart from this, is by contamination of susceptible sites. That could be surgical wounds or catheter drainage systems. Then it could be potential pathogenic organisms which can establish themselves as temporary or permanent colonizers. Transient microorganisms are also easily transmitted from healthcare workers' hands to other vulnerable service user sites, and also by touching contaminated surfaces. So the simplest and the most effective procedure is hand hygiene, which has to be performed, and maintenance of skin integrity is important. We need to cover the cuts and abrasions with waterproof dressings, keep nails clean and short. Nail brushes should not be used for cleaning the hands, and even if they are used, they should be preferably sterile and a single use. And avoid using wrist and hand jewelry. So let's see hand washing. There are levels of hand washing. There's a routine or social hand washing, then aseptic hand washing, and surgical hand washing, which we call as the scrub. So basically today we'll only talk about routine or social hand washing. Routine or social hand washing removes the dirt, organic matter, and most transient organisms which are acquired through direct contact with a person and from the environment. Washing with soap is important. It's just not washing with water. And a tippy tap hand washing station will help to promote hand washing. Now, water is a powerful and a rinsing agent. It rinses away the dirt, but it cannot easily remove soil or organisms that are attached to the hands. So soap is effective and it maximizes and rinses the benefit. So, am I audible now?
Yes, ma'am.
Okay. So, the optimal amount of liquid soap, is about 0.7 ml, which is a small drop. And this, a lot of research has been gone into it, and it is the best balance between the required effectiveness and economics. If we use 0.4 ml, it covers only 53% of the hand surface area, and it does not produce a cleaning result any better than water alone. So we use a small drop, which is about 0.7 ml, and it will cover the whole hand. Foaming hand soap solutions and others, hand spray can also be used for cleaning our hands. The number two is that we can use the hand sanitizer also. Now there's a question between alcohol-based and non-alcohol-based hand sanitizers. Alcohol-based hand sanitizers are basically ethanol, isopropyl alcohol, and propanol, or a combination. It is low cost, rapidly effective, and it has the effective concentration is at about 70% for ethanol, and it is effective in reducing infectious transmission. You can see ethanol is the best. It is about 85%, then isopropanol, and then N-propanol. It is effective against non-enveloped viruses. We do not know much, but it is effective against SARS-CoV-2 on inanimate surfaces, that is metal, glass, or plastic, since SARS-CoV-2 is a lipid virus. So it is very much effective against the COVID-19 virus. The next one is the non-alcohol based hand sanitizer, which has an active ingredient that is benzalkonium chloride. And in this, it doesn't dry out the hands, and we do not have much efficacy data. So we use only alcohol. And besides that, it is, though it has an advantage that it is less irritating, but since the data is limited, we go for alcohol-based hand sanitizers. Now, hand hygiene, the gold standard is that we use alcohol-based hand sanitizer with about 60 to 70% of the alcohol, and it is given in the WHO guidelines on hand hygiene and healthcare. And there are 5 steps in hand hygiene. First is we wash our hands before touching a patient, before cleaning or any aseptic procedure is done, after touching the patient, then after any exposure to the body fluid, and after touching patient surroundings. So these are the 5 moments of hand in which step 1 and 2, that is before touching the patient and before doing any aseptic procedure, protects the patient. The steps 3 and 5, that means after exposure to the body fluid or after touching the patient and after touching any surroundings of the patient, it is a protection to the service provider. There are several steps in hands washing which have been dealt in detail, and there have been several trainings also. So first is important is the hand washing could be using a hand rub or soap. So this is a pictorial diagram which will show how to hand wash with soap and water and how to hand wash with the hand rub. There are basically 6 moments of hand washing, and the first step is that we will apply a small amount, about 3 ml in a cupped hand, and cover it all through the surfaces. This is for the hand rub. And then rub the hands palm to palm, then back of the hand, then rub palm to palm with fingers interlocked, and then rub back of the fingers to opposing palms with the fingers interlocked. So this will help in using the hand rub. And once the hand is dry, it is safe. So we have to dry the hand. So once we have used the hand rub or the hand sanitizer, if it is greasy, then we have to wash the hands. And the total time, scrub time, is about 20 to 30 seconds. Now, if we have to hand wash with soap and water, we'll take the amount of soap, or we can use any type of soap. And then the same steps are to be followed. That is, we will, rub the hands palm to palm, and then back, and then you clean the web spaces, the knuckles, and rub the thumb, and then the opposite wrist with the opposite hand, and then wash it with ample soap and water. And the scrub time again is 20 to 30 seconds, and the total time would be about 60 seconds, 40 to 60 seconds. So these are the 2 methods, whether we use the hand rub or we use the soap and water. The second thing is respiratory hygiene now. After hand wash, we'll come to the respiratory hygiene. That is, the respiratory hygiene is, we have seen that we produce droplets, or whether they are naturally produced or artificially generated. Naturally would be like breathing, talking, sneezing, and coughing, and artificially would be by doing any manipulation in the healthcare setting. So droplets include various types of cells. It could be epithelial cells, electrolytes contained in mucosa or saliva, and potentially infectious agents, or even molecules which we use, like salbutamol. So these could all be droplet infections. And droplets produced during sneezing, we can say, is about 40,000 droplets. Coughing is through 3,000 droplet nuclei. And even if we talk for more than 5 minutes, it is about 3,000 droplets. And the louder we talk, the aerosol emission increases. So we have seen that talking, sneezing, coughing can emit aerosols to a varying intensity. So all the time when we cough or sneeze, we have to follow some respiratory etiquettes. That is, cover the nose or the mouth while coughing or sneezing, dispose of the used tissue we are doing, and immediately perform hand hygiene after contact with respiratory secretions. And there's a WHO recommendation: if tissue is not available, cough into your sneeze or sneeze into your elbow and not into the hands. So all respiratory etiquettes have to be followed while coughing or sneezing. Then there is a talk about super spreaders. That is, super spreaders are mainly identified in the height site, because it is not possible to know in advance. And infected individuals who can infect many others generate more secondary cases than the expected on an average. And the clinical characteristics of these super spreaders are, they have a heavy dose of infection and shed more virus. Then they may have a severe cough, and therefore they are likely to spread the infection. And in most instances, they have spread infection before actually, we come to know about them. So we have to be careful about the super spreader. There are several research studies and several examples which are highlighted that how this infection, this is all regarding COVID-19. And once they had, done a contract tracing, they have found that how many of the people were already infected by these super spreaders. In the current scenario, the current global propagation of COVID-19 is heterogeneous. There is slow transmission in many countries and exponential in other countries. It is proposed that it could be explained by the cascading super spreading events, and new infections caused by super spreaders are highly infectious, and exposure to high viral loads may result in high intensity of the infection, which exposes new cases to high viral loads. So we have to be careful about the super spreading events. So apart from all these things, we should say that there should be no handshake. We can greet with a namaste, and no spitting in the open. Because if we spit in the open, the ground may be contaminated as aerosols fall to the ground, and the infection can be spread. So to overcome some bad habits, it is important we have a healthy lifestyle and a proper lifestyle. The third one is physical distancing. It's a non-pharmaceutical intervention, and it has a strong potential to reduce the magnitude of the epidemic peak, and it can lead to small number of overall cases. The safe distancing between two people has been seen to be 6 feet. Now, this has been also seen that people can spread the virus, as we know, before they are sick, that is asymptomatic and pre-symptomatic. So at least 6 feet distance away from the other person will allow, to safeguard ourselves from the infection. It has been seen that if a normal behavior, one person can affect 2.5 people, and in 30 days it is 4.6 people. But if the distance is more than 6 feet, the spread of infection, that is, if it is 75% less contact, it is about less than half of the people can be infected, and in 30 days it will be only 2.5 people. So physical distancing is a good way to stop the spread of infection. So most important is that the epidemic peak has to be flattened, and this can be achieved by physical distancing also. Now, if we have to see an example, see a simulation exercise, we can see that in 200 people in a town with one sick person, we can see how much of the people can get infected. You can just see the slide and see when there are no restrictions, absolutely people are mingling up. We can see that in the 200 people, healthy people, the count of the sick people is increasing, and almost all are getting infected. Though the recovery is also there, but you can see the change over time is there, that the sick people are decreasing and recoveries are also taking place when there are no restrictions at all. But when there is an attempted quarantine, you can see that the infection, the number of sick people is less, recoveries are also occurring. You can see if the changes which are occurring when there is an attempted quarantine in the slide, and you can see the change over time. So you can see that the recovery rate is less, number of sick people, you can see the change. That is, there are sick people also, 49, and the recovered is 151. So you can see that there is a change in the, when there is an attempted quarantine. Now, if you have a strict quarantine, there you can see that the change over time is important. There are very few sick people, and the recovery rate is also increasing, and many of them are healthy. If we continue it with an extensive distancing, which is most important, you can see that the number of people sick are less. You can see the time also. The sick people are less. The recovery rate is also high, and the healthy people are also there. So when there is extensive distancing, when we maintain the distance, the number of sick people is less, the recovery is also higher, and the number of healthy people are also many. So this is important that we maintain a distance between each other. So physical distancing is stay away from other people who are not from your household, or both in the indoor and outdoor spaces. Moderate social distancing usually better than extensive. And as COVID-19 has a multifactorial complex, that is the transmission risk, a combination of all these strategies is important. So it's not just that one hand washing will help, it is all of the strategies have to be followed. So the last one is the universal masking, and we know that masking is very important, and we have to maintain, we have to be masked up all the time. So masks, we have several types of masks, and we have medical masks, we have surgical and N95 masks, we have non-medical masks, which are the cloth masks. So best you can see that if an infected and an asymptomatic person is there, if both are masked, the number of exposure or the number of infective agents are less, and the person can be saved when both persons are using the mask. A medical mask is usually a triple layered mask, and it creates a physical barrier between the mouth and the wearer, and the potential contaminants in the immediate environment. So it is 3-layered. The outer layer is the fluid repellent layer, which is darker in color. The middle layer is a barrier to the germs, and the inner layer is for moisture absorption. N95 masks with respirators and without respirators have been used, and these respirators block at least 95% of the very small, particles, that is about 0.3 micron. And N95 respirators, they are subject to regulation around filtration capacity. They are not, designed for children, and they are to be used by medical personnel. So these are the, how to wear a mask safely. That is, the nose should be covered completely. The mouth has to be covered. The mask should not be left dangling under the chin, which is not to be done there. And it should be a tight fitting mask. So a medical mask needs to be worn securely. Cloth masks are also available, and they have to be certified. That is, they could be ISO certified or CITRA certified, and they also, have a filtration efficiency. They are reusable, and usually there are 7 layers of it. They are also splash and fluid resistant, and they could be reusable up to 30 gentle hand washes. So cloth masks are also used and can be used by the general public, but they have to be certified masks. Now, the masks have become the new normal, and the mask parameters are important. That is, they have to protect the person actually. And the protection is by various studies which have been done. They have to pass through certain stress tests, which will give protection to the masks which we have to use in the common. So these are that they should also be scalable, comfortable, reusable, and of course they should be cool. Disinfection practices is the last one which we have to talk about, and we have last time also talked about these disinfection practices, and though it may be a repetition, but contaminated, we need to know again and again about it. So contaminated fomites can transmit COVID-19 in a healthcare and in a non-healthcare setting. In a healthcare setting, it is furniture to the fixed items inside the patient rooms, medical equipment. Then non-healthcare settings, it could be sinks, toilet, electronics, furniture, countertops, stairways, rails, grab rails, floors, and walls. So there has been several studies on this in which we have seen that, the virus can spread from a single contaminated door handle of an infected person to other office buildings also. So there are studies, so we need to follow certain disinfection practices. The first one is to clean it with soap and water and some brushing. And this can help to reduce the pathogen load and the organic matter also. And then we use a common chemical disinfectant, which is commonly used, which is hypochlorite. So these are the chlorine-based products. This is sodium hypochlorite, which can be used. And chlorine solutions are effective. They are quite inexpensive. And these should be prepared freshly every day. That is most important. And they are to be stored in opaque containers. And, the date and time and the concentrations are variable. And we need to know how to, use it, use these use the hypochlorite. Then spraying and fogging, it's not actually recommended because it causes risky to the eyes and causes irritation to the skin. Formaldehyde is also not used for spraying. It's not recommended. We have certain no-touch technologies, that is vaporized hydrogen peroxide and UV radiation. And then outdoor spaces such as streets or marketplaces, spraying with formaldehyde is also not recommended. But we do it in our OTs, so that but then that is closed, and there's a specific protocol which is to be followed for spraying and fogging. The frequency of cleaning of environmental surfaces according to the patient areas with suspected or confirmed COVID-19 patients is, if it's a screening and a triage area, we clean it twice daily, and focus is on the high-touch surfaces, and the floors is the last. In patient rooms, it is again twice daily and 3 times also, which includes the high-touch surfaces. In the inpatient rooms, which may be unoccupied, it is upon discharge or transfer. Then outpatient rooms, again, after each patient visit, it is to be cleaned. And there is a special guidance that we have to clean the high touch surfaces, that is the doorknobs, the toilet spaces, they have to be cleaned at least twice. Hallways and corridors, clean them twice daily. Patient bathrooms and toilets are also to be cleaned twice daily. And if it's a shared toilet, it has to be cleaned thrice daily. So the frequency of cleaning of the environmental surfaces has to be done. The disinfection, as I said, we can carry out with ethanol, that is spirit, chlorine-based products, that is hypochlorite, then hydrogen peroxide, and the contact time is 1 minute. And the percentage of hypochlorite which is to be used is 1% and 0.5%. So all these 3 measures taken together can help to beat this COVID epidemic. So it is physical distancing, use of face mask, eye protection, hand washing, and use of disinfectants, and maintaining a healthy atmosphere can help us to beat this epidemic. Now we come to safe injection and waste disposal. Now, in this, we will talk about what are the safe injection practices and prevent unsafe injections, improve injection safety, correct use of AD syringes, then waste management of the immunization waste and disposal of the immunization waste. So as we know that safe injection practices is one that does not harm the recipient. First is the recipient should not be harmed. Then there should be no exposure to the health worker also, and the waste which is generated, which is dangerous to the community, is to be disposed of safely. So no reuse of the injection equipment, no wrong injection techniques, and no wrong disposal of the the waste which is generated. Now the beneficiary, we can see the impact of unsafe injection practices is beneficiary it can have a risk of contracting hepatitis B, hepatitis C, HIV, and risk of parasitic, fungal, or bacterial infection, or there could even be an abscess. The functionary is the one who gives the injection, then it could be injury or infections, and the community at large is because we can have infections, there is waste generation, and there can be a polluted environment. So unsafe injection practices can cause harm to the beneficiary, to the functionary, and to the community. So it is very important to have safe injection practices. Now, what are the the unsafe practices? Number one is reusing a syringe. So we do not reuse a syringe or a needle. We have to have sterilization monitors. That is, we monitor the sterilization with time, temperature, and steam indicators. Then no reuse of the syringe or the needle. Then giving an injection when there are safer alternatives, keeping the freeze-dried vaccine for more than 6 hours after reconstitution, loading syringes with multiple doses and injecting it with the same needle to multiple persons, applying pressure to the bleeding sites with used material or a finger, leaving a needle in the vial to withdraw additional doses, or mixing two partially opened vials of the vaccine, flaming the needle, storing medication and vaccine in the same refrigerator, and touching the needle. So these are some practices we need to avoid. That is, never reuse the needle. We have a proper sterilization monitors, then change the needle every time, give an injection with the AD syringe. The freeze-dried vaccine should not be opened and left outside for more than 6 hours. Never load the syringe with multiple doses and inject for multiple persons. There should be no application of pressure to the bleeding sites, then leaving the needle in the vial to withdraw additional doses. So we do not use these methods which can harm the recipient. Then there are certain practices which can harm the healthcare worker also. That is recapping the needle or placing needle on a surface or carrying them to any distance prior to disposal, sharpening the blunt needle or block needle for reuse, and reaching into a mass of used, syringes or needle. That means cleaning or sorting of waste. And then these will really harm the healthcare worker and any infection can be caused. The community is because if we leave the unused syringe in areas where children can play, it can injure them. Then recycling to unauthorized vendors can be there, and leaving unused syringes in areas accessible to the public. So these procedures can actually harm the community. So improving the injection safety. How do we improve? First is conduct immunization at a clean place. Clean your hands before giving injection. Use sterile injection equipment. Discard contaminated vaccine and injection. If injection site is dirty, you have to wash it with water. Do not give injection on infected skin. Prevent needle stick injury. Select a correct syringe for administering the vaccine. Do not use a damaged syringe, opened syringe, or an expired pack. Do not touch the needle or the rubber cap of the vial, and do not recap, bend the needle, or leave the used AD syringe. Cut used syringe at the hub, immediately after use. So these are the AD syringes which we have been using now. These are auto-lock syringes or auto-disabled syringes. They have a ring and a lock mechanism, and it automatically breaks the plunger if reuse is attempted. And a prominent graduation ensures dosage accuracy, and it has a clear, transparent barrel. Then we have to use the correct syringe. Check the packaging. Do not use if the packaging is damaged, opened, or expired. We peel, open, or tear the package from the plunger side. So important is that we peel, open, or tear the package from the plunger side. Remove the syringe by holding the barrel, and discard the packaging into the general waste. It is paper and it goes into the general waste. Then remove the needle cover cap and discard it again into the general waste. Then do not move the plunger until you are ready to fill the syringe with the vaccine. Do not inject any air into the vial, as this will lock the syringe. Take the appropriate vaccine vial, invert the vial and insert the needle into the vial through a rubber cap. Insert the needle such that the tip is within the level of the vaccine. So it has to be, the needle has to be put straight into the vial so that it is in level of the vaccine. If inserted beyond, if it goes above, then you may withdraw, you may draw an air bubble, which is difficult to expel, and do not touch the needle or the rubber cap. Now, once the vial, has been, the syringe has been loaded, pull the syringer back slowly to fill the syringe. The plunger will automatically stop when the necessary dose of the vaccine has been drawn. That is 0.5 ml. Do not draw the air into the syringe. In case air, is accidentally enters into the syringe, then remove the needle from the vial. Hold the syringe upright and tap the barrel to bring the bubbles towards the tip of the syringe. Then carefully push the plunger to the dose mark, that is 0.5 ml, expelling the air. Clean the injection site if dirty with a clean water swab and inject it into the arm. So these are the safe injection practices which we had talking about, and I would like to thank from the updates which we have taken from ICMR, WHO, CDC, NHS, NHSRC, and NCDC. So thank you very much for so I hand it over. I hand it over to.
Thank you, ma'am. Thank you very much. It was
a
nice presentation and very informative to all of us. Once again, I would request to Worthy Principal, ma'am, to conclude the session with vote of thanks to all the participants and today's resource person. I also want permission to bind up the session after our introduction, ma'am. So please once again come out and unmute your mic and address the meeting. Kindly unmute yourself, ma'am. Yes, ma'am. आप करिएगा, ma'am. Yes, please. Sorry, ma'am.
So today we had very good discussion about this infection control and in safe injection practices, and of course with the revision of that COVID-19 pandemic infection, that contagious disease we are all going through. So anybody listening this webinar having any questions, please come forward for your questions. So any doubts?
You have my presentation also, so it can be
We will
mailed.
share it with all the participants. We will share it, madam, with all the participants.
So it's okay.
All are very keen to have the presentations of the facilitators, जो भी हमारे साथ आप लोग जुड़ते हैं और बहुत अच्छा बताते हैं. I'm very grateful to you. And today is a Sunday, so you have spared your valuable time
Thank you
for giving this presentation. So thank you very much. And this was very informative, and it was very much necessary to revise all these things before we start this COVID-19 vaccination for the younger group from the age group of 18 to 44. So thank you very much, ma'am. There is no such question right now. So I thank you. Thank you. And I thank you all the participants also for joining us. Thank you. So you can bind up, Mr. Dharmender, and thank you also for your cooperation for
Okay,
this.
ma'am. Thank you very much, ma'am.
Okay.
Thank you.